Hello, my name is David Schiff. I'm a retired Kaiser Permanente emergency physician. I'm not an orthopedic surgeon. I had a right knee replacement done 20 months ago, a little more than that, and I'm not very happy, as you'll see, with the results of the right knee replacement that occurred 20 months ago. And I'm scheduled for a revision on the right knee tomorrow. So I'll have a new knee replacement 20 months after the first one. Let me show you some things and talk to you about some things that I think one should know before one gets one's knee surgery. First of all, there's 3 different schools of knee surgeons that I know of. Some who perform a mechanical alignment, some who perform a kinematic alignment, and others perform the customized knee. Going back to my knee, if you see me in the squat position, centered over this line, and both femurs relatively symmetric, you might see that this knee is straight over that foot and the lower leg goes up and down. Here the knee points down over the floor, the foot's way off to the side, and the lower leg is deviated laterally. That's something new to me. Both knees and legs used to perform symmetrically like the left leg before, but no longer since my knee replacement. If I put my feet so that they're symmetric, both pointing forward, and lower myself down into a squat position, because of the new configuration of the right knee since the surgery, you can see the right femur gets driven in. There's a lot of lateral obliquity to the lower leg, and of course, because the right knee gets driven in, it pushes my whole body to the side like this. And you can imagine I'm not very happy with this, but this is the position when my feet are both pointing forward and I go into a squat. If I want a more symmetrical squat, except for the lower leg, I would go like this. I showed my orthopedic surgeon this problem, showed him in the lunge position how this knee goes over the floor or straight down to the floor rather than being over to the foot. And he said, "We can fix that, David. Just move the knee over the foot." Even though that rolls the foot up on its side, and it's no longer a lunge position that someone would normally take. If I take the lunge position on the other side, you can see the knee is over the foot and it's comfortable, the foot's flat. Here, lunge position, foot flat. Everything of the part of the lower leg is off to the side, the foot's pointing outward. And the only way I can get the knee over that foot is to roll it up like that, which is not a true lunge position. The foot isn't flat. Walking. The right foot points out laterally. The right heel points inward. And you can see that makes for an awkward, uncomfortable walk, and the knee is quite uncomfortable now. And because when one walks on 2 rails, one rail for the left foot, one rail for the right foot, one rail for the left foot, one rail for the right foot. I have to make a choice with what I'm doing with my right foot. The left foot, the whole foot, the heel, the midfoot, the forefoot, all travels on the left rail. But with a new right foot that points out to the side, do I walk with the midfoot on that right hand rail? Do I walk with the heel on the right hand rail? Or do I walk with a forefoot on that right hand rail? So the problem is if I walk with a heel on the right hand rail, I rock back and forth as I walk with the heel on the right hand rail because the right forefoot is way over here and the left forefoot is in its normal position, but it causes a very rocky gait, which I don't enjoy. If I walk with the forefoot, the right forefoot on the right hand rail, I have to circumduct the right foot around the left foot, but I don't rock nearly as much. So I sort of have to compromise my gait between the right forefoot on the right hand rail and the right heel on the right hand rail to get some kind of semblance of a gait. And the knee just snaps and cracks and is very uncomfortable when I walk. I showed you the squat. Another thing I can show you is balancing on one leg. The left leg performs normally when I balance on the one leg. My pelvis points straight side to side and my left foot points straight forward. If I try to put my right foot straight forward and balance on that leg, what I ended up is with a pelvis that tilts back toward the left. If I want my pelvis straight forward, what I have to do and balance on one leg, I have to put my right foot pointing way out to the side, which isn't my normal, or wasn't my normal prior to the surgery. It's my new normal ever since my knee has been changed. The other difficulty I have is trying to walk with any speed. The reason I got the knee surgery is because I wanted to be able to keep up with my family when I walked. And now it is just so much worse than it was previously. So if I try to walk, my steps are short and my steps are painful and I'm slow. So this isn't even comfortable, but this is slow. If I try to walk fast, anyway, it feels like the knee just doesn't come together. The metal parts in there just don't meet properly. It has felt to me like my components might be loose from the bone, but I've been told the components probably aren't loose. What it probably is the ligaments are so lax that everything just is loose and feels like it's falling apart. It's especially in the middle of the air that it just feels like things are crazy and snapping and cracking and falling apart. When I bicycle, and when anybody bicycles, and bicycling is one of my favorite things to do, the left leg going through the pedal stroke or pedaling cycle, the knee and the foot stay in line. When I do it with the right foot, forcing the right foot to be straight forward and back on the pedal, it drives my knee in and then down, and then knee in and down, knee in and down as I pedal. My orthopedic surgeon said, well, just adjust your foot on the pedal so that your knee can go straight up and down. He said, set up my toe clips that way. But what that does, it doesn't work. If you know anything about bicycling, your heel is going to hit the shaft of the pedal arm, or it's going to hit the pedal arm if you orient your heel that way and your foot that way on the pedal and you're cleated in. So before you get your knee surgery, I hope you look into whether your knee surgeon's doing a mechanical alignment knee, a kinematic alignment knee, or a custom alignment knee. Mechanical alignment is what I underwent with a Zimmer-Persona set of knee components. I apologize, I got interrupted. There are issues that I hope you look into before you get your knee replaced, if you're considering it. One is the type of philosophy and alignment that your orthopedic surgeon uses to put in your new knee. The other is the tourniquet time used, and the other is the materials used. And lastly, your surgeon's handicap placard authorization policy. So as far as what kind of alignment your surgeon might do, your joint line of your knee is the space between the distal femur and the proximal tibia. There's a joint line and it has a slope from side to side, and that joint line, the space between the proximal tibia and the distal femur, has a slope from front to back. In the custom knee, which seems to me to be the ideal situation, they do some kind of imaging study, whether it's a CT or MRI or something else, to get the exact size of all your natural components. Your native femur, your native tibia, your native patella, and they figure out what your joint line angle was before you had arthritis. And they try to replicate the joint that you would have had before you had arthritis, as to the size of the components that they put in and the joint line angle from side to side and front to back. And that's the customized knee, and that would be ideal. I know it's being done in Europe. I think it's being done some places in the United States, but I don't think it's readily available to everybody. In the kinematic knee, they take off-the-shelf components, standardized components for the distal femur and the proximal tibia and for the back of the patella, and they try to match what would be your native joint line from side to side and from front to back. They try to figure out, just as they did with the custom knee, what would the patient's natural joint line slope have been, and they try to restore you as close as possible to your native knee before you ever had arthritis or whatever your issue is with your knee that has required the joint replacement. Now, in the mechanical alignment knee, which is what I had, they say they're not worried about what joint line angle, side to side, front to back, the patient had before they had their arthritis, or when they had arthritis. The orthopedic surgeons have just decided in the mechanical alignment knee to just make a horizontal cut to the floor and for both the distal femur and the proximal tibia, or it's a perpendicular cut to the mechanical axis of the bones. And then they put the components on, and it's not your normal, natural, native joint line angle. It's a new angle. It's roughly parallel to the floor. The planes are parallel to each other. They put the components on, but then because your joint is extending and flexing through a different joint line than you were naturally built to have, they have to make all kinds of adjustments to the ligaments and soft tissue so that the medial collateral and lateral collateral ligament can, as best as possible, adapt to that new joint line orientation that isn't your native orientation. And it appears that because I got the mechanical alignment knee on the right, that my ligaments on MRI appear to be stretched out, and maybe that's why everything feels so loose and gives me so much difficulty. I don't know if you'll be able to hear it. That's the chair roll. But my knee makes a lot of noise. I think you could hear it a little bit maybe, but when I walk, it's always making that noise. It's hard for me to do it in front of the camera. Other issues that I mentioned that you might look into are tourniquet time that your surgeon employs. My surgeon left the tourniquet on my leg for my first procedure for 110 minutes. That's almost 2 hours. And the cramps and pain I had in my muscles during the days following the surgery were so much worse than the pain I had in my knee. I looked at my surgeon's operative note. He didn't even mention that he used a tourniquet in the surgery in his operative note. The surgeon did not consent me for the use of a tourniquet during the consenting for the surgery. I was surprised, to say the least. Many orthopedic surgeons do use tourniquets throughout the duration of the surgery. Some just use the tourniquets for intermittent duration, just the periods where they need a bloodless, dry field during points during the surgical procedure. And other surgeons, it's my understanding, don't use tourniquets at all during the procedure. So look into the issue of tourniquet time and find out what your surgeon's philosophy and practice is on that. Another issue in knee replacement surgery is the materials used. I have a cobalt chromium femoral component. It turns out that if something's wrong with your knee after the surgery and you have a cobalt chromium knee, that's the hardest metal to see through, if you can see through it at all, to find out if there's loosening of the metal component from the cement or the cement from the bone. And they did do an MRI of my knee and they couldn't tell that there was any loosening, but of course there was a lot of artifact in the study, so it wasn't 100% definitive. We'll find out tomorrow when they do my knee surgery whether there's any loosening of the components, but my issue might be all alignment and rotation and my knee not adapting to the mechanical alignment and the laxity of the ligaments that were seen on MRI. The other issue is the handicap placard issue. My surgeon who did my knee is very resistant to giving out a handicap placard to any of his patients more than 6 months after the operation. After that point in time, I guess he feels everybody who he does surgery on should be so much better that they're not handicapped at all. You've seen me walk on the video and you can make your decision as to whether you think I warrant a handicap placard for my challenging, painful ambulation. That's about it. If you're having knee surgery, I hope you do more research than I did the first time I had my knee surgery, and I hope your knee surgery and recovery go great.